Hi, good morning, good afternoon, or good evening, everyone, depending on where you are in the world. This is Ryan Crodel at Valencell. Thanks for joining us for our monthly webinar, this one on AI-powered wearable solutions for senior care and senior living facilities. We are very pleased to have Satish Mova, CEO and founder of CarePredict, with us today. We've still got quite a few people logging into the webinar, so we will get started in another minute or so. So thanks for your patience. Bear with us. We'll get started shortly as we let a few of the other attendees get logged in and set up. Okay, thanks again, everyone, for your patience, and thanks for taking time out of your busy schedules to join us here today for what I think will be an extremely valuable webinar and presentation from Satish Mova, who is CEO and founder of CarePredict, who has a powerful solution around AI-powered wearable system for senior care and assisted living facilities. And I will introduce Satish and hand over to him in just a moment. A few quick housekeeping items before we dive in. This session is being recorded, and we'll share that recording as well as the slides from the presentation following the webinar, as we always do with these monthly webinars. So please do feel free to share those with any of your colleagues or anyone who might be interested who wasn't able to join us here live today. One other point is we encourage these to be as interactive as possible, so please do submit your questions or comments or anything you want us to dive deeper on through the control panel, the GoToWebinar control panel. We will take those questions as they come up. And then we also have some time built into the end for questions as well. So please do submit those as you think of them, and we'll get to those as soon as possible throughout the presentation. So with that, we'll go ahead and dive in. A quick introduction for Satish. Satish is a serial entrepreneur and innovator in the healthcare technology space, and going all the way back to the days of the Palm Pilot and the first mobile EMR on a Palm Pilot, all the way through to EMRs directed at NICU through a SaaS model or a software as a service model, and several successful exits along the way. CarePredict is the current company and what you'll hear more about today. But more importantly, you'll hear about the journey of CarePredict, the problem they're going after, some of the challenges associated with that problem, and some of the promise of solving those challenges in using an AI-powered solution for getting to a predictive model that can help seniors and senior living facilities ultimately help people live longer, healthier lives. So with that, I will hand over to Satish and let him take it away.
Thank you very much, Ryan, for your kind words. And you're right, Palm Pilot and getting physicians to document their electronic medical records in '98 on a Palm Pilot using graffiti, that's what gave me all my white shell. Good morning, everyone. Thank you all very much for joining this webinar. And we're very thankful for Valencell and Ryan for making this possible and inviting us here to speak about our solution. Before I dive into what the problem is that we are solving, I want to give you a little bit about why I went down this path and why we created CarePredict, what my personal journey was. I started CarePredict back in 2013, and primarily I started it because I could not find a solution to take care of my own elderly parents. My dad's 91 today, and my mom's 81 this year. And they live 10 minutes away from me, and I talk to them every day, and I see them once a week. But no matter how many times I spoke to them, when I showed up on that Saturday, I would find completely new and different things that I was not aware of, even though I had been speaking to them every day. And more often than not, the things I found either led me to take them to the ER that day, or pretty much, mess up all of my schedules for the following week from work because I had to take vacation days to get them, physician appointments and take them to see physicians and whatnot. And it really struck home to me that I needed some way of getting objective information about how they are aging, because without my personal human observation, the self-reporting that I was getting from them was not really comprehensive or helpful, and there were these unexpected things going on. And the other side of it is, as they were aging, their powers of observation were declining as well. So I could no longer count on one's observational power to keep the other one safe. And so it became very clear to me that we needed to find some other way of monitoring them at home and understanding objectively when something might be going south, if you will, so that you could react in time rather than be surprised when you show up on that Saturday. And that's when we started looking at the technologies in the space. Pretty much, if you look at aging space today in the remote monitoring of aging individuals, you're going to find the same technology that's been used for the last 40 years in the burglar alarm industry. So you're going to find motion sensors to detect occupancy in rooms. You're going to find those same door and window sensors being used on everyday objects, like a refrigerator door, like a dresser drawer, like a toilet flush handle, to try and track an activity of a particular object so that you can say this individual or this particular activity occurred in this individual's home. The problem with that is, you really can't infer much from motion sensors. It says the room is occupied, but not by whom. So if you have multiple people in there, you don't really know who's occupying the room or what activities they're engaged in. And secondly, the bigger issue is that, just because the refrigerator door switch says the door open and close, it doesn't really mean that you can make the assumption that your parents ate. And those were the kind of leaps of faith that I was not comfortable with. So I decided we needed to create something new that doesn't exist, and really a wearable that's designed for seniors, that can track each individual senior, that can track location within a home, that can answer a lot of the questions I or another adult child of a senior might have for their parents to see how well they are doing. And that's how we ended up building CarePredict. Now I'll kind of dive into what the setup of the problem, the challenges in aging, and so on. And Ryan, if you don't mind, the next slide. So this is a chart most all of us are familiar with if you're in any way cognizant about how the world is aging. Where we are, about 600 million of seniors around the world are over the age of 65 plus. But, not too far distance, about a fifth of the world is going to be over the age of 65. 1.6 billion people by 2050. And those are stunning numbers. It's one of the largest demographic shifts ever in human history. In prior times, we didn't live long enough because of poor care and poor, general lifestyle, environmental habit, and other issues. But now we are living longer. That's the good news. But the bad news is also that we are living longer. Because as we live longer, a lot of the infrastructure and mechanisms that we have in place are not scaling to that longevity challenge. So, for example, we might not have saved up enough when we retired at 65 to take us all the way through 85 or 90 years or whatever the current lifespan is. And our children, or rather the adult children of seniors who are taking care of their own children and raising them, are having to take care of their parents as well, the classic sandwich generation. And so this, it's impacting quite a bit of other things other than just healthcare. It's also impacting how adult children of senior live and how the grandchildren and how they interact with grandparents and so on. So it's a pretty massive societal problem. But adding to this challenge is the other side of it. If people are living longer, who's going to take care of them? Next slide, please, Ryan. So this shows you the caregiver and the senior challenge. So if you see, the number of seniors are increasing rapidly, but the number of caregivers aged 45 to 64 is coming to that intersection point. Now, this is in the US. If you were to run the same chart, for example, with Japan, these two curves have already crossed. So they've had about 2 to 3 decades of negative population growth, and they don't have a robust immigration model, so they're really not getting any new caregivers and taxpayers coming into their country. So they had, for example, a deficit of about 320,000 caregivers last year. So those curves have crossed. That's a big issue. And how do you solve that? Because it's not just solving it in the US, this is a planet-wide problem. And this is where we kind of get into a shift in paradigm. Next slide, please. So the shift in paradigm is to go more from the reactive senior care model, which is what we do today. So we always react to an event, to going more into a proactive model. And the way to do that is to understand, what are these early precursors that are showing up before a decline happens, so that you can act and intervene in time, so you can catch these signs, use those signs to prevent a bigger issue. Now, to do this, it requires lots of observation. And today we are using human caregivers for all of that observation. And we're using human observation, next slide please, for things like detecting precursors to falls and fall risks, precursors to depression or malnutrition, or people skipping meals, dehydration, or eating enough or drinking enough, and even things like mild cognitive impairment. One of the earliest indicators of mild cognitive impairment is short-term memory loss. People do something, they forgot they did it, and they repeat it again. And these are things that you normally would not repeat. Let's say you brush teeth in the morning, you forgot, and then you go back 10 minutes later and brush your teeth again because you forgot. All of these things today require some human to have observed the event and then question what happened, and then that leads to a clinical assessment of some kind, and that could lead to a diagnosis. But the problem is, if we are relying on human observation to find all these declines, and we just saw the curve where a number of caregivers are not sufficient to take care of the aging population, it really brings us to that conundrum of how do we get beyond human observation. And on top of that, human observation, as you all know, is going to be intermittent. Absolutely, there's no such thing as 24/7 continuous human observation. It's just not scalable. But human observation also tends to be scalable, tends to be subjective. So it's unreliable, inefficient, and oftentimes it's expensive. And so we really need to start thinking about, well, what comes after? To just bring home the point of why this is so crucial. Next slide, please. You'll see that in the past, we had about 5 caregivers to support a senior. This is the times of large joint families, and then large nuclear families that took care of each other. So you might have uncles and aunts and siblings within the same town who can come in and help. So there were really 5 family caregivers to take care of one senior. Now we've come to the point where it's 2 caregivers to a senior. And if you look at certain countries, like, for example, another example is China. China, because of their issues around single child policy, those single children are now taking care of 4 to 6 people, if you financially as well as in family caregiving. It could be 2 of their own children, as well as 2 parents on the wife's side and 2 parents on the husband's side. So the shifts are happening very fast. And the future, it looks like we're only going to have about 1 caregiver to take care of 2 seniors. So certainly you cannot rely on human observation to be that primary driver, if you will, that's going to help all of these seniors to be taken care of. Next slide, please.
Satish, we did have a quick question come in.
Yes.
The question is, it says from the CarePredict website, the CarePredict system will be available for purchase by consumers in 2018. Is it available for consumers yet? And if so, what's the pricing model?
So the consumer product, the CarePredict at Home, we actually announced that at CES in January. We were going to deploy it last year, but we had made some changes to the device to make it cosmetically much more aesthetically improved and whatnot. And that product will be available starting May through June, around that time frame. And the primary distribution channel today that we're talking to are more the curated channels around home care agencies, as well as very large retailers that have their own installation fleet, if you will, that have things like that can go out and install the product. We want to start out on that model first, before we dive into allowing people to do it-yourself installations. That'll allow us to start. And the pricing is still under review, but it'll definitely be very much in line with some of the other products that are on the market. There aren't any direct products that compete with us in terms of predictive analytics, but there are a whole host of products out there around the personal emergency response systems, like life alerts and things like that. Now, we offer a lot more than them, but the price will be somewhat aligned with how the industry perceives them as well.
Got it. Okay, yeah, that's helpful.
Yeah. So this is just a quick overview of us. Our headquarters is in Fort Lauderdale, Florida, epicenter of aging in America. So we're ideally situated with our customer base. And out in Menlo Park, California, we have our data science and AI teams closer to the valley, which is where a lot of the talent around data science is in the US. We also have additional teams. We do our data visualization out of Japan, and some of our mobile apps out of Poland and things like that. So really, we started out as saying that we want to really sell this into senior living, and that's what we've been doing since 2017. And we are deployed commercially in the United States, Canada, and now Japan as well. And it's an all-in-one product for senior living. It has workforce productivity management. It justifies the increase in level of care by tracking, frailty of an individual, and see where the frailty is increasing, so the assisted living facility can offer additional services. So, for example, let's say if my mom is in assisted living and she was independent in bathing and was bathing herself in, let's say, 10 minutes previously, and as she gets more and more frail, it's taking her 30, 40 minutes to bathe herself. Really, in an assisted living facility, nobody knows about that, but we do. So we can actually surface that to the caregivers and staff at the facility, and then they can make that determination. Is mom really still independent in bathing herself, or does she need assisted bathing? And then they can have that conversation with the family and help provide the right amount of care to that individual. Along that line, we're also predicting, and I'll go into more details on this in the later slides. We are really in the prediction business of trying to predict the risk for a fall or a urinary tract infection or a depression, and that's really where the AI comes in. Next slide, please. So this is just a quick overview of our solution. So step one down below, that's our version 2 of our model. That's sold primarily only to senior living facilities. Goes on the wrist of the dominant arm. And it's important to be on the dominant arm, which is why it doesn't have a display or anything like that, because people tend to put devices.
Satish, are you there? Hello, Satish. Satish, we may have lost your audio. I'm trying to confirm if everyone can still hear me. Okay, yeah, it looks like everyone can still hear me. Satish, I don't know if you can hear us. Okay, I'm trying to reach Satish now. Bear with me.
Can you hear me now?
Yep, there you go.
Okay. All right. I apologize. For some reason, GoToWebinar doesn't like my Mac. So, I apologize for that. So just going back to rewinding a couple of minutes back, I was talking about our wearable device. It goes on the wrist of the dominant arm. And it does a lot of kinematics of the arm and gesture recognitions to figure out what activity that arm is engaged in. It also does real-time location tracking within the facility by using these little wayfinder beacons that people put in the facility and around the home and so on. What that allows us to do is track the activities of daily living. Is somebody showering? Are they sleeping? Are they cooking, washing hands, brushing teeth, eating, drinking? And also what kind of functional activity are they in, the walking, standing, things like that. And all of these data points, about 2,000 data observations in a 24-hour period, are sent to the back end, which is where we have all of our neural nets that actually run through them and figure out what the predictive insights need to be. And then those come back down via mobile apps and web apps down to the caregivers in the facility.
Satish, there was a question that came through about the connectivity, Wi-Fi or Bluetooth off the device?
This device has both. Our version 1 device was Bluetooth only. This one has Wi-Fi and Bluetooth, and our next generation one will also have LTE as well.
Got it. Okay, thank you.
All right, next slide, please. So we'll talk a little bit more about the wearable device itself. The way we do a lot of the daily activity sensing is by sitting on the dominant arm, looking at the kinematics of that arm, looking at where the wrist is in 3D space, what the angle of the elbow is and the angle of the shoulder, and have all of these kinematic algorithms go through for example, in our current version is the support vector model, which looks at all the features, about 84 different features, and tries to classify what the activity of the arm is. Is it lifting a fork to the mouth? Is it brushing teeth? Is it brushing hair? Or is it raising a cup for a sip? And those are important, but they're also inherently noisy signals because me raising an arm to scratch my nose is very akin to me raising a fork to my mouth. So it's somewhat of a noisy signal, but what we do is we bring in additional contextual sensors all around it. So location tracking, we know, and the time. So we know you're in a room that you normally eat breakfast in, around the time that you normally eat breakfast in, and we can count the number of lifts of the fork to the mouth to understand how much you ate. But if you miss one or two, or we get a couple of noisy ones, it's okay, because the whole activity of how long did you eat is much more important, or did you eat is much more important than precisely how many fork lifts did you take to your mouth. And the device also has additional sensors, contextual sensors, that help us detect things like bathing by looking at the room type, as well as other features of that room, and understanding what activity is happening in that particular room. Now, we use the Valencell heart rate monitor since our version 2 product, and there were multiple reasons for that. And one of them is obviously, very accurately to determine the kind of sleep activities. You really need a heart rate component to detect depth of sleep and things like that, not just motion. A lot of the sleep trackers out there use simply accelerometers to detect passive sleeping and just restless sleep by looking for angle changes on the arm. So generally, if you're having restless sleep, your arm tends to move a little bit, and as long as you detect that, you can say that's a restless sleep. But if you have a heart rate monitor, then you can dive deeper into what are the levels of sleep an individual is in. And that's extremely important, because sleep is one of the earliest precursors for declines in health that you'll see in an aging senior. Typically, people heading into depression will have restless sleep. People who have a higher chance of falling tend to have restless sleep, but also get up and out of bed at night a lot more frequently than those who don't fall. And there's just a lot of reasons for tracking things around sleep. And to really do sleep well, you really need a heart rate monitor. Now, the other reason we also put it in is also for catching some corner cases in particular markets. So, for example, in Japan, they don't shower as much. They tend to bathe in bathtubs. And there's also a high incidence of drowning in bathtubs. And one of the ways you can detect if there's a drowning event, perhaps, other than stationing a human observer outside every public bathtub, is to actually, try and detect if there's a spike in heart rate as the drowning event occurs and things like that, or during a stroke, or even to make sure you can reduce the number of false positives of a fall. Post fall, is the heart suddenly racing? People who fall, their heart will race. So there's really, really important reasons why you really need to have an accurate heart rate monitor. And then on the other side, one of the biggest challenges with wearables, you all know the story about people buy a wearable, and then 6 months later that Fitbit is sitting in the sock drawer. It gets old because people forget to put it on, or they don't want to put it on, or what have you. But one way to detect if a wearable is being worn is really to detect presence or absence of a heartbeat. I mean, it can mean other things, but this is a one rudimentary use case to say, are they wearing it or not? And then the other features that we put into the product include two-way voice. So when somebody pushes a button, the caregiver's app rings, and then they can, through the app, CarePredict app on their smart device, they can actually talk back to this individual who pushed the button. And that's super helpful, because a lot of time when people push buttons on the existing technologies, there's really no way for you to prioritize. Now, did they push the button because they've fallen and it's an emergency, or did they push the button because they need to go to the toilet and need to be escorted, or they just need a particular soft drink brought to them, or what have you? So it allows the caregivers to prioritize that. And we've also added additional features for senior living, where the device can be used as door access control, things like that. So they won't forget to wear it when they walk out of their suite, because this is how they get in and out of their apartments and to other common areas of the space. And we've also incorporated things like fall detection, as well as voice confirmation of falls to reduce false positives and so on. And then we also had to put in some additional contextual sensors. And this is important because for you need to understand what the environmental context is that's within that home. If they're in the bathroom, is it what act are they performing? You can try and deduce if they're bathing by looking at some of the environmental monitoring there and trying to understand how much water vapor is in the air and stuff like that. So this is really a purpose-built device for seniors specifically, and it's solely intended for them to use very easily, very quickly. No user interface on it other than voice services. So you can even later this year you'll actually be able to talk to it and invoke Alexa or Google or one of those voice service platforms as well. Next slide, please, Ryan.
Satish, a couple of questions have come in.
Yeah.
First one was, will I know if my mother is at risk of falling, or does it tell me that she fell?
Both. So we have fall detection, and we also have fall prediction. So fall detection is something that lots of people do today, but they're almost all only using things like accelerometers to detect G-force shock. And the problem with that is they're very, very high false positives. Seniors tend to, as they're walking, their hands bump into the wall or their hands bump into the table, and those G-forces are very akin to somebody falling. So there tends to be a lot of false positives on accelerometer-based fall detection devices, which is almost 99% of the detectors out there are accelerometer based, and then the false positives lead to a lot of alert fatigue. So caregivers, don't react to them as well as they should. Now, some of the other fall detection companies have started introducing additional sensors to try and absolutely make sure that the person has indeed fallen. And we've gone one step further, and we use all of those sensors, but we are also using now things like heart rate, as well as because of the understanding we have around the individual and the contextual information we have. So, for example, we know, if you're a diabetic and we know you skipped a meal, you're more likely to fall because you're going to have a hypoglycemic reaction. Things like that. Or on the flip side, if you're a diabetic and you just eaten, you also have a sugar inrush problem as well that could also cause you to fall. So we have additional context. So we do fall detection around that, but also fall prediction based on your sedentary behavior, your gait, your stride length. So we can actually come up with a score that says this person is more than likely to fall in the next week. So it's both preventive as well as reactive. Because falls will happen. Falls are inevitable, whether they are systemic because of a decline in health or whether they're accidental because they tripped over something. Falls will happen. So we need to be on both ends of that spectrum.
Got it. And I want to come back to a question that came in before we lost your audio. I didn't want this one to get lost in the mix. There's a couple of questions that have come in around battery life on the device itself. So what's the battery life? How often does a user need to recharge it?
Right. Our version 1 had an internal battery, and that lasted anywhere from 5 to 7 days, and it was wirelessly charged. But the issue we found with that is if people take it off their hand, off their wrist, then it's a chore to remind them to get it to put back on. Then you have to send reminders and all kinds of social engineering to remind them to get it to put back on. So our version 2, for example, the one you see on the screen, that has replaceable, rechargeable, swappable battery. So you never need to take it off your wrist. If the battery pops off, it's magnetically latched. You put on the charger, charges up, and then you slap the battery. You take a freshly charged battery. We send these devices out with 2 batteries each. So one's always on the charger being charged, while the other one is in use.
Okay, great. One other question related to AI, and I don't know how much you want to get into this without giving away any secret sauce, but a question came in about what kind of AI is required, if machine learning, what model is good enough, what do we need to measure and why, and is any of the monitoring for prevention, which I think you've covered that already. So a question around the AI and machine learning systems you guys use.
Absolutely. So we have to use all facets of it. So we use machine learning. in the device itself to try and figure out what activity that dominant arm is engaged in. So we use support vector models, things like that. But once it classifies that activity, and then it has to use clustering to actually bracket the behaviors together, and say that this is where the number of forklifts that happen at this time of the day, and so this is probably an eating activity, and so on. Now, once the data gets to the back end, that's where the longer range predictions happen, and those are all just deep learning neural nets. And so what we've done is we had this thing in pilots in senior living facilities for about 3 years, from about 2015 to about mid-2017. And we were able to train a lot of those data sets at that time by actually labeling the data. So we would actually send in our nurses into those facilities and, for example, do a depression questionnaire every 2 weeks on all the residents there. So we could label the data and say which ones were under depression using that clinical assessment and which ones weren't. And so the neural nets got trained on that data sets, and so understood what were the correlates that were the precursors, if you will. These are not causation, so remember, these are all just correlation. What were the correlates that correlated to a particular outcome, whether it's a depression, a fall, or a UTI? And my next few slides will talk about some of those correlates as well, so we can certainly get into more questions when we get to those slides as well.
Okay, yeah, and looking at, there have been a couple other questions come in, but I think you're about to address those in the next slides. If not, we'll come back to the questions.
Excellent. All right, so this is just the end-to-end solution. It's basically telling you all of the things that we're using, and the screenshot is an example of one of our dashboards. It's showing you the location, when, the eating patterns and all. We'll go into a little bit of a detail. And this slide really talks about the neural nets and the correlation engine that's connecting all these things together, and how it's sending it into the apps, the CarePredict app, whether it's iOS, Android, or the web app, and then how caregivers are actually using this to do preventive and predictive type stuff as well. So next slide, please. So this is our dashboard. This is actually screen slices from our dashboard. This is showing, for example, on the left side, the nutrition actionable insights. It's showing the person had lunch but missed a dinner last night. So that's why you see the eggs, and then they had breakfast this morning. So that kind of skipped meal detection is super important, because skipping meals is generally indicative of something going wrong. Whether it's indicative of depression, it's sometimes a depression, either people overeat or undereat. But skipping meals could also be general sign of malaise, where they don't really want to interact with anyone. They don't. They want to get into this entire self neglect type of a syndrome, so they no longer want to take care of themselves. That's one. But on the other side is, as people age and frailty increases, failure to thrive, where people start shutting down and stop eating and things like that, are very, very early signs of potential morbidity as well. So it's really important for you to know if people are getting into that pattern of they're not eating. On the right side, you'll see, for example, our little graph from our app, where it's showing you when this person normally eats their breakfast and how much time they spend eating breakfast, and that's in aqua, to the purple, which is when they really ate breakfast this particular day, for example. And same for lunch. And if you see eating activities outside the normal breakfast, lunch, and dinners, those are essentially, we classify those as snacking activities. So somebody may skip meals, but you might see an increase in snacking, so they're compensating one way or another. And like I said, snacking is, to us, is just an eating activity that's outside their normal times and locations. And the bigger issue is really trying to understand what the trend lines look like. So these are not instantaneous, results that you need to look at and be worried. You want to look at the trend line. And that's the middle of the right part of the screen, where you're seeing that purple line starting to go down, and that's showing pretty much that they're on a general decline. And so this person is somebody that probably is heading into a failure to thrive type condition, and probably needs intervention of some kind, whether it's a social worker or perhaps therapy or whatever it might be. And down below to the bottom right, you'll see the skipped meal, just more data of, are they skipping breakfasts or lunches or dinners. Each of those columns are for a week. So for example, this person skipped 2 lunches, 3 dinners, and 1 breakfast in the last week we had data for. Next slide, please. So next slide is about urinary tract infections. UTIs are very common once you get past the age of 70 plus. So it's something that comes with frailty, both men and women, but predominantly women. And if you look at the Medicare statistics, it's one of the largest expenses Medicare has is treating UTIs. And UTIs are if they're caught in the first 24 to 48 hours, they can be very simply treated usually by oral antibiotics. But if they get into the 4 to 5 day range, then the person is septic, passing blood, and about the only thing that solves the problem at that point is IV infused antibiotics and a hospital stay. So the cost can run from $4 copay for oral antibiotics to a $50,000 hospital stay 4 days later. So it's very, very important to get, to catch UTIs very, very early. Now, it's been well known forever. I shouldn't say forever. It's been well known for quite a while that frequency and duration of bathroom visits are very indicative of a potential UTI. So people with a UTI get the urge to go, they go into the bathroom, nothing happens, they leave, and then the urge either stays or becomes more urgent, they go back in. And those are, if you're doing full real-time location tracking like we are, and also looking at additional contextual information around that individual, like we are, then we can correlate that, if they're going more often to the bathroom but staying shorter times of period, shorter duration, that's usually indicative of a potential UTI or some other kind of an infection starting. So these are all probabilities. We're not diagnosing anything. We're not in the business of diagnosing. We are just saying that there's a probability this person, may be having some kind of a problem that somebody needs to intervene and look. And typically in our models, in senior living, there's a nurse or someone who will come in and say, and go talk to that individual and see how they're feeling and do the triage themselves. So there's a human clinical intervention component that comes in that actually does the diagnosis. We are just raising the trigger that says there's a potential for an issue here. And we're letting the human caregiver do the diagnosis. Next slide, please.
Satish, a question somewhat relevant to this slide. Any plans on adding adult incontinence to the ecosystem, or I guess to the predictive model?
It's one of those things that we looked at very carefully, and there are connected diapers. I think SensorSure was one of the first that ever came out with a connected diaper. Those are better done through the adult diaper manufacturers, because if somebody's incontinent, they are on a diaper regime, and now the question becomes, how often do you change the diaper? In the current model, if you look at it, if adults on diaper are constantly being bothered by staff to check and see if their diaper is full so they can change it. Now, the issue is that if somebody's sleeping and you're constantly waking them up to check, that's disruptive. But if you had a connected diaper, which I believe SensorSure actually created about 2 years ago, then you can actually know when the diaper is full or how full it is and make the decision on do you wake the person up or not. Because a diaper that's full, that's not changed, can lead to all kinds of skin integrity issues and infections. But we would more than anything be connecting to a device like that to understand, the incontinence and things like that. So that's a very good question, actually, because we actually cannot detect anything around UTI for somebody who's incontinent and is on a diaper regime, because there is no bathroom visit we can detect.
Got it. Yep, that makes sense. One other question that has come in related to audio sensors, if I'm interpreting this question correctly, asking about, does your machine learning process take inputs from audio sensors. The example given is the user of the device or the user of the system is reading a newspaper, and the audio sensors sense or hear the newspaper pages turning over. Can you comment on that?
That's very interesting. We don't do that today. We do have ambient noise in our model, in our roadmap, to track ambient noise, but it's around context. So we don't want to turn on the microphone and listen. We think it's invasive of privacy. That's also one of the reasons why you have to push the button to talk to Alexa or whoever on our product in the forthcoming iteration. We don't want the mic being on all the time. But that said, we have context. So, for example, if we detect a fall, we can go mic on to see what exactly is happening, and is the person sobbing, is there cries of pain, that kind of stuff. But we haven't really thought about trying to detect or analyze, the whisper of a page turning or the clink of a cutlery to indicate additional type information, mainly because we are very diligent about privacy and don't want to turn that mic on unless there's context that supports that mic being on. That said, that's a very interesting area for us, and we're definitely spending some time there.
Great. Moving on to the next slide.
Right. So falls, falls, as somebody said, we do both prediction as well as detection. Now, falls are very interesting. Having a fall is the single greatest inflection point in aging. The statistics are, if somebody over the age of 70 falls and breaks a major bone, 25% of those people will die in the first year, and nearly 100% will die within 5 years. Falls just start that spiral into decline that aging folks do not recover from. Our bones are more fragile, and the minute we go into a hospital for any kind of major surgery at that age, that starts the spiral that we never recover from. So to prevent falls is the ideal thing, because if you can prevent a fall, a person lives their normal lifespan. It is that dramatic an inflection point. So we look at falls as a multifactorial problem. We look at amount of sedentary behaviors that are leading to, for example, balance issues because their muscles have atrophied because they haven't been very active. We look at things like have there been gait changes or stride length changes. Because a lot of these indicators are actually clinically correlated for a higher risk of a fall. But then we also look at things that are non-traditional, our deep learning nets, for example, can see that if somebody's walking or pacing longer times when they get up at night in the week, that also leads to a fall the next day. So those are the kind of things we are looking at, that not just the traditional clinical models, but also things that are based on activity and behavior patterns that we've instrumented the senior for and can actually have the benefit of the data. This is one of the first times ever that anyone's instrumented a senior to this degree and understand at this level of granularity all the activities and behavior patterns people engage in. And I can tell you it's eye-opening, some of the behavior patterns we see around seniors. Lots of seniors we see wake up at 2 or 3 in the morning and go sit in the living room for an hour or two, and then they go back into sleep. And those are things that we see as part of their normals. So that's why it was actually very important for us to understand what the baseline is for the individual. And as part of our machine learning protocols, we want to look at between 7 to 14 days of data, the initial 7 to 14, to set up the baseline and always look for anomalies from that baseline, rather than try to say the baseline for example, for a woman 70 plus years old is to go to the bathroom 2.3 times a night and try to benchmark against that. We try to benchmark against that own individual's normal, if you will, baseline, and find the anomaly from that. Next slide, please. So depression is another major one. I talked briefly about it. Basically, it's one of the most common undiagnosed diseases in the elderly, and mainly because a lot of seniors today are aging in low stimulation environments or aging alone, away from very close-knit family and friends, and loneliness is a big leading cause of depression. But how do you detect depression? Typically today it's being recognized through human observation. trying to see if somebody has unkempt hair, hasn't brushed hair, hasn't bathed, still in pajamas at 3 in the afternoon, is staying away from sunlight, or staying in a darkened room and doesn't want to interact with other people, or meal habits are swinging wildly. Those all require human observation. So we are able to look at the things that we are capturing around eating, drinking, bathing, and all of that, and also come up with in a senior living facility where there are plenty of people around, are they shunning other people when they normally would be more social? And we're taking all these factors in and saying, okay, these are the correlates that are showing that somebody is going to be depressed a week from today, for example. And we had to do a lot of labeling of data in the past around depression, where we actually went and did the PHQ-9 questionnaires for all the residents and try to label the data so we can understand what the correlates are. And next slide, please. So in senior living, our product is the wearables are not used just only by the seniors, but also by the staff. And the reason for that is, it's a controlled environment. All the staff are there. We do full real-time location tracking indoors. So facility operators are actually using our product to track workforce productivity, to understand, how quickly people are responding to button pushes, and who's being efficient and who's not, and also to document all the care that's provided when people push a button, what exactly was the reason and why, and what care was provided. So again, we're even opening up the black box of workforce operations within a facility, because a manager can't keep their eye on every staff member at the same time and understand exactly what they're doing. With our product, they're actually able to track all of that, and also post-incident. So let's say somebody fell or something unfortunate happened, they can actually replay all of our location maps, hit the replay button, and actually watch and see where everybody was in relation to that incident, and understand exactly what happened, and help forensically understand how to better improve their existing operations and things like that.
Satish, yes, sorry. Question come in. This is lots of information that caregivers have not had access to. They're not trained to see or react to so much data. What does the training, the staff training for the system look like? How long do you think it takes to change practice?
That's a very insightful question. And that's where we run into a little bit of a problem with the US model versus the international model. So in the US model, caregivers, especially in senior assisted living facilities, such as Alzheimer dementia centers, assisted living facilities, are all non-clinical, and it's a social or hospitality model. So some of these insights we surface, it becomes very hard for them to understand what the intervention should be. So if I were to say this person is likely to have a UTI, vast majority of assisted living facility staff would not quite know what to do about it. So we actually layered in a nurse call center in the back end as well as part of our offering, where registered nurses look at all these population health reports every morning, and they can look and say, these are the 5 residents that are at risk at this facility for a UTI, and they are the ones who are actually calling that individual and triaging their symptoms, and then helping make that communication to the physician of record for that resident. And so that the physician can get involved. More often than not, the physician is usually sending a home health care nurse to do an assessment and to figure out the symptoms under the Medicare benefit, and they can provide the service. In international models, nursing is very much part and parcel of assisted living and Alzheimer dementia care facilities. So they have that expertise in-house, where they can actually, once they're shown what the potential prediction condition is, they can actually react to it and do the triage themselves. In the CarePredict at home model, we're also going to be offering a call center backend as well, a nurse call center backend as well. But they're the primary consumers of that information, if you will be the adult children and family caregivers and so on, who will get that information, and more than likely will reach out to the physician of that individual and say, report the symptoms, and see whether that physician wants to see that individual or what further intervention is needed.
Got it. Okay. Looks like that's it for the questions now. So moving on to the next slide.
Okay, so again, this is just continuing the staffing model, and this slide is really showing how facility operators are actually able to increase their average length of stay of the individual, so that they are, by avoiding hospitalization for UTIs and falls and things like that, but also that they are really understanding for the first time, what the response times looks like for taking alerts, and when the alert is taken, what are the kind of assistances they're providing. So this is actually allowing facility operators to better manage, what kind of staff, what particular skill sets are needed at what time of the day and in which portions of the buildings. These are insights that they haven't had to before, or only had it anecdotally, but now they're getting really objective data that they can actually build a very good, efficient staffing model around. Because number of caregivers are declining. You need to be able to do more with less. And the best way to do that is to send the staff and the intervention to the exact person that needs it, rather than, in a general area, reach out to people who don't need it. So what we are allowing to happen is essentially become a force multiplier that's allowing care staff to understand who needs care and get them directed there very quickly. And the next slide. So this is a quick screenshot of our CarePredict at home product. This is just going to be coming out, like I said, in May, June timeframe. This was announced at CES in January. And this one is completely geared more towards a family caregiver, but also looking at longer range trends as well as immediate alerts. And family caregivers, whether it's an adult child or son or a daughter, can actually, when mom pushes that button, it'll actually come to their app on their own personal phone. They can actually talk from there straight to mom onto her wrist, and actually be more connected and be more in touch, and really understand, you get peace of mind by understanding where things are declining with their loved ones, so they can act sooner. I'd rather know that mom is waking up a lot at night and walking around a lot at night, rather than have to find out by getting an EMT calling us saying that mom fell and they're taking her to the hospital. So it drives peace of mind for the adult children to know that there is a safety net at home that's continuously observing mom and understanding what's going on, so that they have that prescient sense. And the last slide. All right. Wonderful. Thank you very much for the opportunity to speak to you all today, and happy to take any more questions if you have.
Thanks, Satish. That was really insightful, and you guys are certainly tackling a big problem and doing it well. So it's great to see. We have had a few other questions come in, one of which you just addressed, which was, are there home solutions as well as the professional assisted living facilities? You just covered that. Let's see. Oh, no, I guess there aren't any other questions. Several people have just said thank you for taking the time to explain this and share all the information. There was a question about, will the slides be shared? And in case you missed that up front, we will share a link to the slides as well as a link to the recording of the session here. So please do share those with anyone you think may be interested who couldn't make it today. Here's a few more questions that have come in. And Satish, I know we're at the top of the hour here, so I want to be respectful of your time. Do you have a few more minutes to answer some additional questions?
Absolutely.
Let's see, have you seen any, if I'm interpreting this question correctly, there's a question that came in around patients not tolerating the device itself, or any data you've seen around adherence to wearing the device?
I'm sorry, Ryan, could you repeat that?
Oh, sure. Have you seen any issues with adherence to wearing the device, or patients not tolerating wearing the Tempo device?
Relatively sparse. In all the senior living facilities we are in, we have extremely high adherence rate I think one thing I would say is that it's a little bit of an education to get them to wear it the right way. Sometimes they might wear it upside down and things like that. But yeah, we have in general extremely high adherence into the 90s. I think in Alzheimer dementia care, we have more holdouts because the nature of that disease is that people don't tolerate wearing anything, including clothes or jewelry of any kind. So it becomes a little bit of a challenge with some of those folks. But those settings are also where you have more eyes on them anyway, so it doesn't detract from the overall solution.
Got it. Yep, that makes sense. Had a couple of questions come in related to just the market in general about are there specific personas or sub-segments of seniors where this kind of solution makes most sense? And then a similar question around how are you finding first adopters for the technology?
Yeah, so I would say the personas are, when we started this, we thought it's 65 plus. And we found that's not necessarily the case, at least in the US. I mean, there are people 55 plus that are in assisted living facilities, whether it's because of certain disease states, chronic conditions, or what have you. So it became very hard to say that it's a particular age range. What we look at is, more than anything, somebody who needs assistance with 2 or more activities of daily living are ideal candidates for this product. And also people who either have a history of UTIs or have a history of falls. Those are all the ideal people to use the product.
Got it. Next question is, and I'm not sure I understand the question, so we may need some clarification here, but the question is, have you considered the link with API solutions? I'm not sure which API solutions are being referenced here, but so perhaps the questioner could clarify a bit.
In a generic sense, we do have APIs that we connect with other people in the ecosystems, especially in senior group living. We connect to pull cord vendors, we connect to the EMR vendors and things like that to move data back and forth. So we are certainly doing that. We are also going to be connecting more with the other connected devices that might be in use either in the facility, whether they're for capturing vitals or things like that. In the generic sense, we are very open to connecting to other partners in the ecosystem.
Got it. Next question. Thanks for the talk. I'm wondering if you offer the Tempo solution without the beacon sensors in the facility or the home. Will it work without the beacons?
It can, but that leads to a reduction in the contextual information, and that's super important because you really want to, and that's what's been missing in a lot of these solutions out there, is they lack the context. And that's actually one of our strengths, is that we have the context. We have the context of where you are, what kind of room you're in, and that helps us better understand what activities you're actually engaged in.
Yep, got it. Quick follow-up on the previous question about APIs. It says, my question is directly looking forward to link the data you receive to a private healthcare facility. So I think you addressed that in your answer.
Yes.
Next question, what kind of processor do you have in the wrist-worn unit? Do you pre-process sensor data, or is the raw data pushed to the cloud?
We do both. We do Cortex M4 in there, and our own flavor of an RTOS running on there. We do a lot of the processing on the device, on the ML side of the SVM classifier and things like that we're running there. And then we push the classified data back up into the cloud. But as part of our development protocol, we also can command a device to send raw data as well. So let's say if we are seeing an unusually high noise ratio for certain people, we can have them transmit the data in batch mode, the raw data for some of the sensors, for example. So we could do better backend modeling of that particular individual and see what's going on.
Interesting. Next question is, can the device be tracked if it is misplaced?
Yes, unfortunately, that's a feature that we actually had to put in after our first Alzheimer dementia care facility. So there's actually a find my tempo where the device can be commanded to start making a beeping noise and flashing its light, so you can go help find it. Yes.
Great. Let's see. Next question is around what is the financial benefit to the facility where this is installed? Do you have any data on cost benefit?
Yeah, we are actually finding that 4 months after deploying our product, the facilities are seeing about 20 to 25% reduction in falls. They're seeing increases in average length of stay. They're seeing about 61% improvement in response times by staff to resident alerts. So they're seeing immediate benefits. So they are looking at all that, and that's their ROI that they're getting out of it.
Got it. That's great numbers. It looks like that may be it for the questions. With that, I know we are over time here, so I'll just say, Satish, thanks again for your time and all your insights. This was a really fascinating presentation, and love what you guys are doing. So thanks again for taking the time and sharing all the insights.
Oh, thank you very much, Ryan, for this opportunity to present to your audience, and I really enjoyed myself, and those were fantastic questions.
Good. Yes, indeed. We've got a great audience here. So thanks. Speaking of the audience, thanks everyone for taking time out of your busy schedules to join us here today. And as I mentioned, we'll send out links to the slides, and the webinar recording should be within 24 hours. So let me know if you don't get those for whatever reason. And otherwise, we will see you next month for our next webinar. So thanks again, everyone. Have a great day.
Thank you.